Hello and welcome to Lynchburg Live. I'm your host, Linda Smith. Approximately 270,000 total knee replacement surgeries are done every year in the United States. Celebrities Michael Douglas and Liza Minnelli have made the talk show rounds talking about their experience with having had total knee replacement and how it's enriched their lives. My guest tonight is Lynchburg orthopedic surgeon Dr. William Andrews, who will be telling us about total knee replacement and answering some of the questions that you may have. Dr. Andrews is a repeat Lynchburg Live guest. He was here last year, and it's so good to have you back.
Nice to be back.
We hear so much about knee replacement. It just looks like everybody in the whole world has had one. It makes me wonder if we're just wearing out our knees. Can you tell our audience what conditions lead to the necessity for a knee replacement?
Well, in the simplest fashion, it's some kind of arthritic condition. It could be arthritis from wear and tear, which is the most common. It could be arthritis from an old injury. It could be even from an infection, although that's much less common. So it's some condition that wears down the joint.
Like athletes, for instance?
Athletes, if they've had an injury. If you haven't had an injury, you're not more likely as an athlete. But athletes are more prone to have a knee injury, the running, jumping athletes. So they're more common down the road if they have an injury and it doesn't heal completely.
What about people that just don't have any background like that and end up with rotten knees?
Well, I would say most of the people we treat weren't even significant athletes. They might be recreational tennis players, recreational joggers. Arthritis, I think, really in the weight-bearing joints doesn't necessarily have to imply that you were a great athlete. I just think there's a lot of wear and tear on the knees and the hips. The knees more than the hips, and over time they just wear down in a lot of people.
What role does age or heredity play in something like this condition?
Heredity is a very small role because there are a few conditions that might be hereditary, but most conditions like wear and tear arthritis don't really have anything to do with heredity. Age does. As we get older, our cartilage gets thinner and gets less resilient, and so it's more easily injured just by living your life and walking and being a normal person.
Are all joints candidates for this kind of condition?
To a degree. A lot of joints are easier to replace than others. The knee and the hip are the most commonly replaced. The shoulder is replaced with some frequency. Joints like the elbow, the wrist are much less common, and the ankle has come and gone in popularity. There's now a new ankle replacement that's being done some. So it really varies joint to joint.
Because we have such a limited amount of time, I'd like to focus primarily on total knees. Younger people are having knee replacements more today. I know it used to be thought of as something that was an older person's operation.
Absolutely, and part of that was when the knees first came out in the late 60s, it was a very different design. It was a hinged design, and they didn't last very long. When I started my training, which was in 1980, the basic premise was you never replace someone's knee if they were younger than 65,
right,
even a little later, because we thought they were going to wear out so soon, and we didn't want to be continuing to replace them. As the design has gotten better, we've started replacing people earlier and earlier. So it's really not an old person's problem anymore the way it used to be. And it used to be that we really held out on doing people who really deserved it because we were worried about how long they'd last.
Right. So what's about the average age?
I would say the average age is probably late 50s now. And when I was a resident, if you even considered somebody under 65, it was almost considered, that you were crazy.
You brought some knee models.
I did.
Can you show us on one or both of these knees where the major problem areas are?
Sure. What I have here is two models of knees. The first is one that does not have anything in it, and it's a replica of a normal knee. What I've done is I've pulled back the kneecap, so you're looking at the kneecap from its undersurface, and the undersurface of the kneecap is kind of a little bit of a wedge shape. It then makes a joint with the end of your thigh bone, which has a nice, basically, track for the kneecap. And then this is the shin bone down here. Sitting on top of the shin bone is the cartilage. And this cartilage, or the cartilage on the end of either bone, is what wears down and predisposes us to arthritis.
Right. What symptoms are associated with this?
The most important symptom in terms of deciding what you do about it is pain. Patients can swell, patients can have catching or locking where their knee doesn't feel like it's moving smoothly. Some patients feel instability, but really the critical issue in terms of whether you're going to replace someone's knee or not is how much pain they're having and whether the pain is interfering enough with their life to replace it.
Right. And the pain is intense.
Very intense.
No question about that.
Right.
How do you diagnose it?
How do I diagnose arthritis?
No, the need to have a joint replacement.
One of my professors always said that he never replaced people's knees until they were waking them up at night. He felt that was kind of the threshold after which you really couldn't go on. And that's not an absolute, but if you think about it, if you can live with something and get a good night's sleep every night, it's a lot easier to hold off on any surgery. Once you're not sleeping well at night because of the pain, then it becomes a much bigger deal.
Trust me, been there.
I know.
Are there other procedures or lesser procedures, less major procedures that you can try before you get to the point of having to have a total knee?
Yes, and of course there are other things that aren't even procedures. We will inject people's knees either with a cortisone-like equivalent called depomedrol or a newer substance called Synvisc. If someone has a lot of what we call mechanical symptoms in that their knee is catching and locking, but their pain is not terrible, you can do an arthroscopy where you go in and kind of clean out the knee. And a lot of patients will get good relief. Some don't, but a lot do. And so those should all be tried before you talk about any kind of replacement.
All right. We hear so much on television about buy this product over the counter. This is going to stop your knee pain. This is going to stop your joint pain. How effective are those?
Most of them are about 50-50. There are patients who really seem to get a lot of relief from them. There are patients who get none. Basically, there's no harm in trying them, assuming you don't have an allergy to the substance that's in it or something. They're expensive, and I tell my patients I wouldn't try them for more than 4 to 6 weeks. If they didn't get better, I wouldn't continue to use them. And the problem, like all things that are advertised, is they always sound a little better on the advertisement than they probably really are.
So you do think they kind of help some people occasionally?
They do, and they do no harm.
All right. This is a big question. Can you sort of give our audience a Reader's Digest condensed version of a total knee replacement?
Certainly. And I did bring a model just to show you a little bit what it's like. When you replace a knee, what you're doing is you're trying to take out the bad irregular cartilage and then a very, very small sliver of bone, just enough to get your artificial replacement in. And so we have now these very exact cutting guides, and we have different sizes of these prostheses that will fit exactly on that patient's bone. So with the cutting guides, we take a straight cut into the tibia or the shin bone. If you look here, we take a much different cut into the thigh bone. It's an angled cut, and we have a cutting block that does that. And so this will fit very nicely on the end of the thigh bone. This part will fit very nicely on the end of the tibia or the shin bone. And then we flip the kneecap over, and we cut this wedge out so it's a smooth surface, and we replace that with a plastic cap. And we cement all these pieces in.
Cool. I just think it's remarkable that we can do this and that I'm wearing one.
I know.
How large is the incision usually?
The incision goes from about 1.5 inches below the bottom of your kneecap to about 1.5 inches above the top of your kneecap. You know, and it goes right down the middle, right down the middle.
A lot of people are really concerned about the size of